Morning, everyone. It's great to see you all today. My name is Ha-Young Kim, and I'm prosthodontist. I run a private clinic in Seoul. Before we start, I would like to thank Dentistry for giving me this great opportunity to present here. And I also want to thank all of you for coming today, especially on a weekend. Today, I'm going to talk about a topic that is becoming very important in our daily practice. The title The title of my presentation is AI Enhanced iOS, another leap in digital dentistry. The person on this slide is someone you all know, Jensen Huang from NVIDIA. He's probably talking about the difference between traditional computing and modern computing. In traditional programming, engineers make the rule. We put the data into system and we get an output. Everything follows the fixed rule, so the results are predictable and consistent. But modern computing is different. In machine learning, we give some model, data, and correct answer at the same time. Then the model learns by finding pattern by itself. It does not just follow rule. It makes its own logic. In other words, this process uses trial and error, and it's very similar to how humans learn. Briefly speaking, AI can be defined as all kinds of computing that is aimed to solve the problem like humans do. Let me show you an example to help you understand AI. There is a website called Teachable Machine by Google. With this platform, you can easily try a classification using machine learning. The process is very simple. You make the two class, and then you put the image into each class. After that, you train the model. For example, I put 10 photos of myself into class 1 and 10 photos of my dog into class 2. After training, the model can look at the webcam and tell what it sees. It gives a probability, is it a person or a dog? As you can see, it works pretty well. AI is changing many industries, especially computer vision, and dentistry will not be an exception. In dentistry, we already use digital workflow, but traditional rule-based system often has a limitation. But I believe AI help overcome this limitation, and its role will continue to grow. This diagram shows how AI is used in dental prosthodontics. First, generation. Generation takes the largest portion. It means creating something new, like a crown in CAD software. Detection and segmentation also account for the significant portion of the field. Detection is the process of identifying objects in the picture. Meanwhile, segmentation goes steps one further. It helps us separate important area after detection. So detection, segmentation, and generation are often used sequentially in many digital workflows. Here is a simple example with my dog. Detection, segmentation, and boundary detection. In dentistry, we need to identify the specific reason from a single image or a scan. Then we separate them from the background as an individual object. After segmentation, we can trace the boundary of the object. If we assume dog is a prepared tooth, this boundary becomes the margin. Once we define the margin, AI can generate the crown based on it. Of course, dental 3D data based on the intraoral scanning use a different model and can be more complex. Recently, AI segmentation has been introduced in Dentium CT Viewer. It can automatically segment the maxilla and mandible and individual teeth and even the maxillary sinus. In this instant segmentation, each object is separate can be saved as an individual file. Then user can import individual data into CAD software and use it for the specific purpose. This makes the workflow more flexible and customizable. This kind of personalized and visualized data is very useful for patient communication. For example, in sinus surgery, we can show how we'll approach the area and what will change after surgery. This helps the patient understand better. Now, let's look at different diagram. Most AI learning is a process training model using data. So we need to understand the model to some extent. This shows the main types of AI model. One of the most important model is the CNN, which stands for Convolutional Neural Network. It plays a big role in computer vision, especially in dentistry, because we work with a lot of images. Let me briefly explain how CNN works. Let's take a zebra image as an example. The model looks at the image using small filter. This filter helps the model, small filter. This filter helps the model find the important feature and make the feature map. After creating feature map, we apply the filter again. Then we get a new feature map. After this process repeat, the layer become deeper and model learn more complex pattern. Over time, the model combine these feature and learn what makes a zebra looks like zebra. The reason I explained the relatively complex CNN model is that it forms the basis of AI technology used in intraoral scanner. AI already being used in intraoral scanner to achieve more accurate and precise data acquisition, and its application will continue to expand in the future. Based on this background knowledge, now let me talk about how we used AI in intraoral scanner. Let's take a look at how AI is currently applied in intraoral scanner and how its application will expand in the future. Drift correction can be considered as the first example. As you can see in this video, the scan size, the scan tip of the intraoral scanner has a limited size. So the final scan data is created by stitching image together frame by frame. Let me explain this process in more detail. The diagram shows how AI intraoral scanner acquire data sequentially. For each frame, the scanner gets data in forms of a point cloud. Then it compares the point cloud and make the alignment between frames. This process keeps going until we stop the scan. We call this process stitching. It aligns the point cloud between frames using the ICP algorithm. During this process, small alignment error can occur and accumulate, which is called drift error. Some people call that the stitching error. So we need to understand the data alignment process to minimize these errors. ICP, one of the most representative data alignment, has two types, point-to-point and point-to-plane. Of these two, we should focus more on the second one. Point-to-plane ICP minimize the point-to-surface distance along the normal direction. It's fast and robust and good for surface matching. For this reason, point-to-plane ICP is commonly used in dental application. Point-to-plane ICP can control vertical movement efficiently, but it may be weaker in horizontal alignment, relatively weaker. A drift error can easily occur more in flat area where many normal point in the similar direction. For example, central palatal surface of upper jaw or a denture. Here are the normal direction of the upper jaw. The purple line shows the normal direction. Most of them point in almost the same direction, which means there are few distinctive features, which means drift error can occur relatively easily. So we should be more careful when scanning this kind of area. This is an example of scanning the maxillary denture. During the central palatal scan, you can observe the misalignment of the data on here. AI finding, to reduce the drift error, AI finding the matching feature in each frame and help to align the data more accurately. CNN-based model can be used for this task. This becomes even more critical in denture case, where the inner and outer surface need to meet precisely along the single line for a complete scan. For this reason, in the past, denture duplication was difficult with intraoral scanner, so it mainly done with tabletop scanner. But now, anyone can do it with intraoral scanner. The second technology where AI is applied is noise filtering. When we increase the scanning depth, unnecessary tissue can also be captured, such as buccal mucosa and tongue and even mirror. In the past, we have to manually remove these unwanted data during the scanning. However, as you can see in the video on your right, the AI filtering function automatically removes these unwanted tissue, and it also corrects incomplete scan in real time. So we can save the scanning time and effort. Lastly, AI can be applied to boundary refinement to improve the reproducibility of the surface. After scanning, the raw data is optimized during the modeling process. At this stage, excessive noise is automatically removed, making the surface clean and smooth. After that, the surface looks more natural, but sometimes we get unexpected results. In this process, too much smoothing can cause the loss of fine detail. The area with sharp geometric change, such as line angle or margin, are more affected. As you can see on the left, if the smoothing or mesh optimization is too aggressive, the margin may become averaged out between the two marked points. As a result, the margin can become blurred or shift. This effect becomes more noticeable when the mesh density is low. Some clinicians refer to this phenomenon as edge loss. If there is too much optimization on the occlusal surface, it can even affect the occlusal contact point. In this workflow, smoothing is necessary, but it inevitably causes loss of fine detail, especially at the margin or end occlusion. So we need to drive balance. I believe AI can help to solve this problem. It can remove noise and then reconstruct the surface. This is an example of a refined scan. On the left, with refined scan on, you can see the more detailed surface feature. On the right, without refinement, the surface looks smoother, but fine details are lost. These are the advantages of using AI-enhanced intraoral scanner. AI reduced the drift error, so accuracy improved. AI removed the soft tissue and noise, reducing the scan failure. AI clearly defined the margin, making it easier to identify. As a result, AI reduced operator dependence, enabling more consistent results. Now, let me show you my clinical case. This female patient is 82 years old. She had been using the complete denture and mandibular one-piece fixed prosthesis for a long time. As you can see, the remaining mandibular teeth were in poor condition, but treatment has been delayed because they were connected by one-piece prosthesis. Finally, long span bridge was fractured, and she decided to proceed with treatment. The gingiva healed after extraction of the remaining teeth. For elderly patients over the age of 80, my usual first treatment option would be the maxillary complete denture and mandibular two-implant overdenture. However, the mandibular ridge was too thin, so it was difficult to place the implant in proper position in parallel. Fortunately, she had used a long bridge for many years and strongly preferred the fixed prosthesis. Therefore, we decided to proceed with all-on-4 for the mandible. Before treatment, we made a temporary upper and lower denture as shown. After that, we duplicate the lower temporary denture and align it with impression material for better tissue adaptation. Then we attach the fiduciary marker as reference point for accurate data alignment. At this stage, we typically use highly radiopaque resin. In my practice, I prefer attach the marker to the buccal side of all teeth. For implant planning, we need to align the intraoral scan data with CT data. CT data does not show soft tissue well, so in edentulous patient, an indirect method for alignment is required. Therefore, we made a duplicate denture with marker and use it for data alignment. Now we can see that the data is well aligned based on the fiduciary marker. For this elderly patient with thin ridge, we chose bright tissue rubber implant for minimally invasive surgery. We also planned implant position and angulation based on the remaining bone and prosthetic consideration. For this all-on-4, we planned 5 implants to prepare for possible failure, just in case. Then we designed the outline of this surgical guide. In edentulous patient, guided surgery is very important for implant position and angulation. However, considering aligning error and tissue-supported condition, I think there is still high risk of digital error during guided surgery. So in this kind of case, I prefer partial guided surgery. In other words, once initial position and angulation are set, we often switch to the freehand surgery. So I can easily adjust the plan if the initial position is not ideal. Anyway, we were able to place the implant minimally invasively as planned. After connecting healing abutment, the surgery was completed. This is panoramic view after implant placement. Bright tissue rubber implant make the surgery simple and fast. So I think it's a very useful option for elderly patients. Now we need to scan edentulous soft tissue and healing abutment with intraoral scanner. Generally speaking, scanning edentulous tissue and metal surface is challenging. It can be even more difficult right after surgery because of blood and saliva. However, using AOR Scan 3, we were able to complete the scan without much difficulty. This is the scan data in CAT program. The shape of metal surface, metal healing abutment is clearly captured without distortion. Since the bright healing abutment can be used as scan body, so there is a need to remove it for scanning. After scanning, we matched the implant library to scan data in CAT program. This allowed us to reproduce three-dimensional position of the fixture. Some intraoral scanner can also use AI to recognize and match the scan body automatically during the scanning. Now, it's time to acquire extraoral scan data for patient intermaxillary relationship. We may remember duplicate denture with attached marker. After leaving the intelligible surface of the inner the duplicate denture, we place the impression material the inside and put it into the patient mouth and ask them to bite. Then we scan both inner and outer surface of the denture. This extraoral scan data allowed to reproduce the patient intermaxillary relationship. Now we need to align the coordinate of two scan data set. First, we choose at least 3 matching points between two data sets. Then the intraoral scan data is automatically aligned to extraoral scan data using ICP based on the 3 reference point. This is the result after coordinate alignment. Considering opposing teeth, we can confirm that the intraoral scan data is aligned in stable position. In previous lecture, Dr. Won talked about the Dentium CT viewer. Now it's time to use this function. We need to arrange the teeth considering facial appearance. For that, we need to reference line. CT viewer can help with this instead of facial scanner. In the CT viewer, AI automatically finds landmark, and based on this landmark, the vertical and horizontal plane are defined. We can also define the occlusal plane considering a traverse line by adjusting Hounsfield unit. We can save all files, including STL file from DICOM, and send them to the rep technician. Then the rep import all these files into CAD program. Then they align them with intraoral scan data based on the reference point. This is the result after alignment. Based on the aligned data, the lab designed the custom abutment and provisional restoration on top of them, considering mid-suture plane and occlusal plane. Patients often feel uncomfortable with lower complete denture, so we want to restore the chewing function as soon as possible with fixed prosthetics. In particular, considering good primary stability of the implant and complete denture in the opposing arch, we thought the cross-arch one-piece prosthetics, the provisional restoration, would be appropriate for early loading. This is fabricate custom abutment and G using provisional restoration. The custom abutment and newly fabricated provisional restoration have been delivered in the maxillary. Even without any occlusal adjustment, we can see that the occlusal contact points are relatively stable. As you can see, the provision was delivered on day of stitch removal. So the gingiva has not fully healed yet. At this stage, the patient eats better and feel much more satisfied. While waiting for implant osseointegration, we made the maxillary complete denture in a conventional way. Now it's time to make a final restoration for mandible. This video clip shows scanning of the mandible provisional restoration and custom abutment with Aoral Scan Elite. Compared with the previous version Aoral Scan 3, the Elite is clearly smaller and lighter. And scanning is faster, and it seems easier to scan larger area at once. Occlusal information can be obtained using provisional restoration as a reference. The provisional restoration and custom abutment scan data can be aligned either manually or automatically during scanning process or CAD software. In this process, we use CAD program. When fabricating this types of one-piece prosthetics, metal framework is needed to prevent zirconia fracture at connecting area. The metal framework was made by milling and is an adaptation check on the 3D printed model. This shows metal framework and provisional restoration tried in the patient mouth. Even though this is modelist work floor, there was almost no misfit between metal framework and abutment. The patient was satisfied with the aesthetic, and occlusion was also good. So we could fabricate the final zirconia prosthetics without additional design change. This is my last slide. The patient was very satisfied with new prosthetics and has been using it well without any problem so far. Today, we learn how AI can be used in intraoral scanner. Since this lecture includes quite a lot technical content, it may have been a little bit boring. Nevertheless, I truly appreciate all of you for attention. Thank you very much.